Hey everyone, welcome to this special podcast series brought to you by Keebler Health and the American Academy of Home Care Medicine. We appreciate you all tuning in and join us. In this conversation, veterans of our industry, Hank Ross and Jeremy Powell, will discuss the evolving landscape of home-based primary care, particularly the shift we're seeing now from fee-for-service to risk models, and how that's changing care delivery and patient outcomes. We hope you enjoy.
Hi, I'm Hank Ross. I'm the current president of the American Academy of Home Care Medicine for the C6 board. I built and sold one of the largest house call companies in the country. I've also started and sold off to private equity hospice home health companies. And before that time, I'm recovering hospital CEO. Glad to be here.
Thanks, Hank. And for you all in the audience, I'm Jeremy Powell, serial entrepreneur, been in small, early stage or growth stage businesses since the early 2000s. Almost all of that time at the intersection of technology and improving clinical and financial outcomes. And so looking forward to connecting with you, Hank. It's you're a bit of a national treasure, and it's always fun to hear your thoughts about things. So we'll jump right in. Well, welcome, first of all. And we'll jump right into some of the thoughts I've had, and maybe we can just bounce back and forth. So tell me what you're seeing in the market as it relates to home-based primary care.
Oh, great. And Jeremy, great to see you, by the way. You're looking great. Home-based primary care has been on a journey, Jeremy, as you and I both know. And if I had to sum it up, I think we're on the 20-yard line getting ready to throw the winning touchdown pass. And the reason for that is that the economics of home-based primary care have been very difficult, as you are aware, on the fee-for-service side of the equation. And, there's 2,400 or so home-based primary care practices in the country. A typical practice is 300 to 500 patients, 2 to 3 providers, or lifestyle practices at their best. Their margins are thin, and it's very hard to scale those types of practices. I was able to scale my practice, but I had to bring private equity in to help me do that. So, but they're out there doing yeoman's work. They are seeing the sick of the sickest patients, our most costly patients in our system.
Mm-hmm.
But I'm sure we're going to get into was a lot of these payment models that we've been experimenting with over the last 15 years, and especially this latest model, this high needs reach ACO, I think is a game changer.
Oh, I agree. I agree with your sentiment about where we're driving towards the goal line, and the Lombardi trophies almost within our grasp as we think about what the market shape is taking around home-based primary care. I'm also interested in, and I wonder if your thoughts collide or align with mine. What do you think about like the generations of patients, the families, and the physician or nurse practitioners? We have this silver tsunami happening where aged adults from the baby boomer population are aging into Medicare. So many a day, I think 10,000 a day, I think is the number that most people throw around. How do you think that influx of patient need and our aging, physician population is playing out in this 20-yard run towards the Lombardi Trophy?
Well, I can tell you, I'm getting calls, with people who are interested in home-based primary care who have never had an interest before. I field a lot of calls from, private equity type people because of this model change. And what's really interesting, and with the announcement from CMS that they want everyone an upside downside risk, by 2030, at least that's a goal for them. The models that you and I have been playing around with for the last 10, 15 years, especially again, this high needs reach ACO. I mean, that is a prototype model for that type of risk population. So I think as people learn more about home-based primary care, and I think as more people are kind of forced into more of a capitated full risk model, I think there would be a tsunami of people who want to talk about how to do this and where to go. I mean, that's what it feels like to me. I know we've been at the tipping point many times in the past, but Jeremy, this feels a lot different to me. Would you agree?
Yeah, I agree. I think the success of the high needs portion of REACH, where it's like by most measures 5 times better outcomes than any other CMMI model or even Medicare shared savings model, Like there's a lot of opportunity to get this part right. And as I mentioned, the baby boomers aging in to Medicare at such a rate, they're going to expect care to be delivered differently. Like the future of healthcare is at home. I don't think that's in question. Most market, like banking and capital players, are looking at, with the rise of AI and the workforce shortages, that care delivery is going to have to shift in some material way. And a homebound, patient or home limited patient opportunity is really intriguing to the banks and into the capital market. I also think that nurse practitioners are becoming a bigger and bigger player, that'll shape this market. And in a model like this where they get credit for attribution, like there's a lot of wins for them as well. Yeah, so I think
No,
we're
I couldn't
aligned.
agree
What
more.
do you?
And
What's that?
what's so great about this model is that, come back to the high needs reach model, is it's such a win-win for everybody involved.
Hmm.
Obviously, the patient wins.
Hmm.
We're able to address their care needs in the home and address those things we couldn't address before, like social determinants of health, food scarcity issues, things like that. And obviously, we have a financial chassis for the first time. It makes sense for our primary care people to be in a home versus fee for service. And, some of the more innovative people out there now, that if you have a nurse practitioner or a physician, nurse practitioner pod system, managing these patients, and you generate savings on those patients, the really good, sophisticated people out there are giving part of that savings back to the practitioner who's done all the hard work in the home. So there's a lot of upside to these models.
Yeah, I always thought about like the advent of the ACO and like legislation was like 2011, and then when it was like found in the wild in the real world in 2012, um, there was a heaviness about like governance and the number of quality measures and how much surveying and assessment you had to do. Like the concepts were right, but the delivery required you to scale parts of your ecosystem that were not affordable. With Reach, with all the things we've talked about, there's also this very low touch, sort of deployment wraparound that's needed because all the quality measures are done by claims-based analysis, which Medicare does on your behalf. And then if you need, some CAP surveys, there are only 4 vendors that do them. So there's not like you're doing all this assessment and surveying yourself. So I think they have empowered the clinician to have the opportunity to get most of the monies because they are delivering the service, right? So I do think that's a good fit for most parts of healthcare that's looking to serve patients in the home. I wonder, of all that market activity in your experience of late, what's the most intriguing to you? Like, what's the thing that goes, this is going to be the game changer?
I think what's really intriguing. I want to make a comment on your prior thought about
Yeah,
the clinicians. Um, in an industry that is really on burnout in most healthcare providers, right? And prior to these capitated models, it was really supply side economics. The more that you could do on a fee for service scale, the more you get paid. But now we're taking those patient panels down with these new capitated care models.
yep,
And instead of maybe a primary care person managing 250 patients in a home, their panel size are maybe more like 120, 130. And what we're saying to them is, we got the capitation, manage the patient to keep them out of the hospital in the ER. And so it kind of slows them down a little bit, makes them pause, makes them really think about chronic care management. And with that type of level of service and that level of satisfaction with those caregivers in an industry that had such burnout, I think that's another win with this model. Would you agree?
yeah, I agree. I always think about capitation as the gym owner who's getting the membership fees paid by all the people that belong to the gym. And fee for service is the yoga or spin instructor who gets paid for whoever shows up for class. And you want to be the gym owner in this scenario.
Yeah.
So a capitated arrangement's not unlike collecting membership dues if you sort of think of it in that way. And whether the weights get lifted or classes are attended doesn't matter for how you get paid so much as you get to define a model of care and you get to drive outcomes. And I think that's what's unique about models like this is you can, to your point, start including care coordination and engagement between visits. Some of the things that I've seen people work on that's maybe the most intriguing from my experience is like changing the expectation of what the digital front door in healthcare looks like. I compare ourselves in this area to like Amazon or Apple, and not say to an EMR vendor's portal. Like, I don't think that's what we should be shooting for in home-based primary care, because our patient connections are very narrowly aligned to encounters, and then there's this real space between those encounters where if we filled that space with capturing symptom detail, understanding what medication refills are happening, being able to hear from the sister or daughter, whoever might be the familial caregiver, about what's going on in between encounters so we can shape the model of care better. Like, I do think this is where healthcare is going to really, really be impacted by technology over the next few years, alongside of this really great capitation and payment methodology.
No, we used to go out and find a room full of coders, right, to maximize or at least have our
Yes.
chart reflect the acuity of the patient, and people like Keebler and others. And now they've taken that, they've automated all that, and that makes scalability much easier, don't you think?
Yeah, I mean, I was telling someone today, we started building Acclivity's software platform 8 years ago, and it might as well have been 80, because with Chat GPT, large language models, transformers, we didn't have access to those things as part of our development. Thinking protocol code itself. It's a that was, it's almost like that was my dad's version of software, and this
Yeah.
is a whole new world when things like Keebler can literally read, faxed, scanned images, PDFs, and 80% of healthcare data is still in this sort of unstructured format, and then make sense of it, including providing clinical reasoning about why this might support your patient journey, especially if you're at risk. I do agree. I think we're not only is the sort of the rise of our prowess at the 20-yard line and almost to the end zone, but technology's got this a huge groundswell that's happening as well. And the marriage of those two things can offset this burden and the staff. It can offset burnout. It can offset all the shortages we always talked about. It can offset the time between visits. Like, all these things can come together in this sort of perfect storm.
Yeah, if you can populate the EMR, 40, 50% of that can be done through
Yeah.
AI, and it gives more time for the practitioner, with their patient and their family.
Yep.
That's the whole
And
intent, correct?
yeah, and I think about like ambient listening. So large language models are really just these really broad, deep, by definition, sort of understand how to build heuristics around language, how to understand the specifics of what's being said. And they've turned those things into ambient listeners during an encounter. So all of your narrative notes in that encounter can actually be captured and then documented on your behalf. I mean, again, like, these are huge forces that are shaping the primary care landscape. I wonder if we can talk a little bit about your experience in when you knew as a leader, when were you going to, how were you going to, and why would you move towards capitation and risk-based care instead of fee for service? Like, how did you make that transition yourself for your own practice?
Um, well, I mean, I was very fortunate that, the American Academy of Home Care Medicine has been very involved in these payment models, and really supplying a lot of the metrics and data to CMMI. And Jeremy, you've been a big part of that with the Academy and many of the high needs ACOs in the past. You've really been a pioneer. But Jeremy, I was just lucky. We got approached by a company when the direct contracting went to high needs reach, and they wanted to do a house call programs, mostly in a high needs ACO. And I just had some availability at the time. I just sold one of my companies, and I was asked with Dr. Bruce Canosian and others to spearhead that joint venture. And now we're in our fourth year of that model, and the results are telling the tale, right? We Last year in our high needs ACO, we saved an average of 23% of the benchmark, almost 9,400, per patient. And so, and the quality scores, the patient satisfaction scores are right there. So, I got to work with the guys who are doing the modeling, like Dr. Canosian and others. And
Mm.
I really had a kind of a PhD course in high needs ACOs. And so, I've just been really lucky to have been exposed to those types of people and had that learning experience the last few years. And so what I've gained my knowledge is we have to transform to this industry, right?
Mhm.
I mean, you do a great, I think we should remind our audience what's happening from a macro side. And you do a great presentation on this, is where that Medicare has to cap the growth of Medicare, and they want to shift all the risk to the providers to cap that growth. And Jeremy, you do a great presentation. Maybe you should remind our audience why they're moving towards these models.
Yeah, I think you probably can find that through the Academy on some of their resources that are tied to the video webinar. Ryan Barris, who's also hanging around the hoop that we hang around, was a part of that as well as you. We do go through some of the history and maybe just a snapshot of like why it's so important. About every 10 or 15 years in the United States for the past 50 years, we get to a place where we're just about to exhaust the revenue related to taxation that pays all of the Part A, which is the hospital, hospice, home health parts of Medicare. And we're there again. And we haven't even counted for COVID and all the spending around testing apparatus and getting drugs to market and all of that. So there's a real crisis about how the care for our sickest patients are going to be, is going to be paid for. And so this big pressure is always either relieved. The last time it was relieved was in 2009, 2010 with the Affordable Care Act, which the press sometimes calls Obamacare. But we're at that next clip where it has to have a big shift again. And Medicare is seeing like the high needs program, like you mentioned, 23% savings. On the whole, this program is 5x bigger, 5 times bigger than what models have been pushed out by CMMI so far. It's also 2 to 3 times better than any program that's shaped by the Affordable Care Act. So my hope is that those kinds of things turn up as a way that this gets elongated, either through an extension or through new models that come out that take the best parts of this and move them forward. It'll be interesting to see though what does really take shape with the CMMI landscape and CMS and its move of parts around. They always are in this moving chess pieces around to ensure success. So it'll be something I'm sure we're all watching closely. Thinking about your progression from fee for service and the capitation, are there any lessons you learned along the way that maybe you can share some of those war stories or scars with some of our listeners that might be helpful for them to hear?
My father told me early on in my career, God gave you 2 ears and one mouth, use it proportionally.
It's great.
There's are really a lot of smart people out there who've been really dedicated their professional careers to these models. And if you just pause and listen to them, there's a wealth of knowledge to learn from the people who are doing a lot of the analytics, right, in these models and that type of thing. Um, so, I try to be a student of these new models. I try to really, I'm a constant, I'm learning stuff every day, Jeremy, as we all are,
Yep.
in terms of the evolution of these models. Because as we're both aware, this model is set to sunset at the end of 26, but we all feel pretty confident there'll be some type of high needs resolution post 26. I mean, the CMS, we're dealing with this 16% of the Medicare beneficiaries are consuming 67% of the financial resources. And
Mhm.
until we get a handle on those costs, and $1 out of $5 is spent in the US on healthcare, you got to address this very complex, costly population who needs these services, and obviously delivering these services in a home versus a really expensive care setting is the key. And so, I feel like the model is going to come into be another generation of this model. There'll be things to learn from the new model. They kind of made it better and better every time, but it's a very exciting time to do that. So, my advice is really listen to the people who've been out there doing these analytics on these models. But it's such a fun place to be because we're plowing new ground. I mean, we're really setting up the healthcare system that our kids and grandkids may live by in terms of capitated models. So it's just a really fun time to be involved on the cutting edge of some of these payment models.
Yeah, and I think your dad was right. I think, and I do think the audience that is, maybe on this podcast, but also the ones out there had heard other information from other leaders, have started to take up the message with real gusto, because I'm seeing, and I think you're a part of some of those same conversations, like there are only 13 or 14 medallions for high needs conveners today so far to participate. And we're both seeing such growth out of those 13 or 14 organizations where they're rolling participation agreements out to bigger and bigger numbers. We're in Ryan Perez, I mentioned earlier, is a part of the AIP group as an example. I think there's an academy relationship there. They're going to get to like 20,000 or so patients that are under attribution in these models. That's a far cry from the minimum, which was 250 just a few years ago. 250
Yeah.
patients to 20,000. Like, so if we think about that, that's not, in terms of like traditional health plans, that's not a number that they would measure as meaningful. But if you roll up the dollars associated with the kinds of spend for those 20,000, it's adult money for everyone. And I think that's the reality of that kind of money given to these providers under an arrangement like this allows them to really advance their models of care and how they deliver services. All right, so I have one question that I got asked a while back on a podcast, and I thought it was a great question, and I want to end it with that question. If you had a magic wand and unlimited resources, what would you bring to life in healthcare?
Um, well, I think we're moving in the right direction in terms of putting the risk on the providers to keep people out of expensive care settings,
Hmm.
right?
Hmm.
So I think we're on the right direction. And you could talk about universal health care or all those other terms, but we're essentially kind of doing that because 75% of our market's already on some type of capitated arrangement. We're just now addressing this very complex population of patients who we think we found a model that works. And so I think we're on the right side. I think because of all the things that we have talked about earlier in terms of the patient gets the care they need, especially these end of life care patients. They get to stay in a facility or a place where they want to be. There's satisfaction issues with the provider group. And obviously, technology is accelerating all these things. So I think we're waving our wand, Jeremy, right?
Yeah.
I think it's coming to tuition. And you asked a question earlier, I know we got to wrap up, but you asked me what was the most intriguing thing. I just think now we got these large, you and I kind of live in the home-based primary care world, but you have large regional, national hospice home health players. And we just saw the margin compressions that have been introduced for home health
Mhm.
for next year. And that's going to, take a break-even business at best and make it under the water. So with all these margin compressions in the home care sector, it's going to force those types of players, these large hospice home health companies, to move to a different payment
Yeah.
chassis. And I think capitation in the home is where they're going to be. Would you agree?
Yeah, and I think you and I sing from the same hymnal there as well. I have a lot of experience helping organizations sort of think through this um, erosion of margins that have been historically untouched. And Medicare and CMMI specifically look for those pockets to go after whenever they address payment methodologies. And if you're going to squeeze the balloon on the hospice and home health side, this is the next big opportunity for organizations that have been taking some version of PDGM for home health, which is a version of sort of pay for performance under a capitated arrangement. And hospice has been a daily rate for 40 plus years, right? You're on the hook for all the care you've got to deliver against that daily rate. So I think they're primed for it. It'll be interesting though. Maybe what I would say is the intriguing part for me is whoever owns the primary care clinician and the patient attribution owns the modeling from here forward. And so hospice won't get attribution. Home health won't get attribution. Palliative won't get attribution. So if you're going to hold your arms around a patient panel, you got to have attribution in these models, and that's a primary care related function.
Unless they go acquire those assets.
Correct.
And you and I
Cor-
have had those conversations. I think
Correct.
the
Yeah, you
home-based
can
primary
get
care
there build,
sector
buy,
really
and
got an
partner.
awakening.
Yeah, it's you can get there through build, buy, or partner, and I think it's like what's your time to value and how deep are your pockets as to which one you can do. But I agree. I think there is a unique landscape shaping up because of attribution and this huge and growing market around advanced illness for aged adults.
Yeah, desperation, not inspiration, creates change, right?
Yeah.
And I think with all the margin compressions we've seen, I
Mhm.
think we're at the tipping point. And that's
Yeah.
fine. This is where Medicare wants people to be anyway, are in these downside, upside risk models. So people are being forced to get there. But in the end, I think we'll all be better for it.
Yeah. I've always noticed that there's a carrot first, and then eventually they bring out the sticks. And I think even when the sticks first come out, good partners will cover you on some of the downside risks that you fear having like day one.
Yeah.
So like I think your point is well taken. Get in touch with Hank, with myself, reach out to the academy. There are lots of organizations that are set up to ensure your success as you transition from where you are to where you'll need to be in these models to succeed. Well, Hank, as I knew this would be, this is an amazing conversation. I appreciate your time and getting on this podcast with us.
No, I want to thank you and Keebler for helping us put this together. It's a great relationship.
Yeah,
Thank you
of
so
course.
much.